right. Well, thank you, Dr. Lee. Appreciate it. Great questions from everyone. All right. Next up is Dr. Colleen Sabatini. Dr. Sabatini is one of our pediatric orthopedic surgeons here at UCSF. She did her orthopedic residency training at Harvard Combined Orthopedic Surgery Residency Program, and then a fellowship at Children's Hospital of Los Angeles. At UCSF Department of Orthopedics, she serves as the Vice Chair for Health Equity and Academic Affairs. She is a champion for health equity and global health. She is dedicated to improving access to orthopedic care for children in resource-limited settings. On top of all that, Dr. Sabatini also leads a pediatric orthopedic research program in Uganda. And she has actually gracefully postponed her trip for a few days just to be with us today. So thank you very much, Dr. Sabatini.
Thank you, Dr. DeBorja, for having me. Hello, everybody. Woo, it's always a little rough to be put at the end of the day, but Dr. Kamen and I are going to represent to bring this home for the day. Hopefully we can infuse you with some incredible excitement around the topic of infection. Woo! I know you can just feel it, can't you? I mean, hopefully you can't, because then we would need to debride a wound or something. I have no financial disclosures relevant to infection. When we talk about musculoskeletal infection, what are we talking about? Just to frame our discussion today. So we're going to talk about septic arthritis. Did you guys see that? Okay, I'm just gonna hold this. It's not stable. It needs an additional point of fixation. That was an orthopedic term. Now I feel like I'm running a talk show right now. If I'm too loud, just tell me. Osteomyelitis, acute and chronic, with some subacute in the middle, and discitis. So we're going to start with septic arthritis. This is not a happy talk that we're going to be having today, but a very important one. So what are our goals for the treatment of septic arthritis? Well, first is to identify the infection early so that we can treat it appropriately, so that we can prevent life-altering articular cartilage destruction and make sure that we retain motion, strength, and function, and that we avoid long-term chronic disability. So septic arthritis, for those who might be like, what the heck are you talking about, is infection of a joint, all right? So we're talking about any joint in the body, some more important than others when we're talking about infection. In high-income countries, like in the United States, approximately 8 children out of 100,000 children a year have septic arthritis, but that rate is much higher when you move into low, middle, and low-income countries. It really peaks in the first few years of life, which is an anatomy-related issue, as all of the infections we're going to talk about today are. And greater than 50% of all of our septic arthritis cases in the US are usually in children under the age of 2. The hip is involved in about 35% of septic arthritis cases, but it's certainly the joint we talk about the most, and we'll go into why that is. But the knee is also involved about 35% of cases, and then the other joints we'll talk about in a little bit are less involved. This is what we are trying to avoid, and this is the purpose of our talk today. That is a totally obliterated hip joint from a missed case of septic arthritis in the United States of America. So what is the mechanism of infection? Well, for septic arthritis and its sort of sister disease, osteomyelitis, you can get these infections in children from hematogenous seeding, which is most common. So if they have an ear infection or oropharynx infection, GI, GU, anything in the respiratory tract, anything where there's a transient bacteremia, then that can go around the body and seed in bone or in joints. Septic arthritis is very related to osteomyelitis, where you have multiple areas of the body where the part of the bone most susceptible to bone infection is actually intra-articular. So in a little bit, we'll talk about bone infection, but if you have a metaphyseal osteomyelitis near a joint of the hip, the shoulder, the elbow, or the ankle, then you're more likely to have a septic arthritis as well. So it's like it's a contiguous move of the infection. And then you can theoretically have direct inoculation into a joint from a traumatic event. What's happening in terms of the destruction that happens is there's a release of proteolytic enzymes from the cartilage and the inflammatory synovial cells and bacteria. All of those things are having like a proteolytic enzyme surge, and this causes damage to the articular surface, starting within 8 hours of the onset of infection, which is why septic arthritis remains one of the few true orthopedic emergencies. Additionally, in addition to the destruction of the cartilage from the infection and all this raging proteolytic enzymes, there's also a buildup of pressure that can happen in the joint. And particularly around the hip, this buildup of pressure can then compromise the blood flow to the head, and the head can ultimately die, even if you actually get the infection treated. So this is a super important thing to know about and not miss. When we talk about what's causing infection in children with regard to septic arthritis, certainly the most common is methicillin-sensitive Staph aureus, but MRSA is obviously on the rise. We'll talk about this both for septic arthritis and osteomyelitis. And then there's this Pantin-Valentine leukocidin gene associated with MRSA, which is really important to know about because those kids with that PVL gene mutation have higher rates of septic shock, longer hospital stays, more surgeries, and are much more critically ill. When we think about sort of younger children, the 2 to 5s, we want to think about strep pyogenes and strep pneumo. I used to give this talk a couple years ago and say Haemophilus influenza type B is not really something that we think about anymore because with vaccination, the rates of that have gone down significantly. As we're seeing vaccination rates decline in lots of places, we might see resurgence of that as we have with other conditions. So vaccinate. Kingella is really important, although not really appreciated, particularly in the US. It is an absolute emerging infection, usually from the oropharynx in the young. We don't see it so much in the US because we actually don't check for it. But many of our sort of culture negative infections in children might actually be related to Kingella. It's just really hard to isolate it. So you have to use a specific blood culture or PCR test. In some countries that test for it routinely, it is the highest organism related to infection in children. And then certainly for some of our special populations, you have to be really aware. So the non-immunized, like I mentioned, you want to think about Haemophilus influenza. Sickle cell, it's interesting because whenever you talk about infection in sickle cell, everybody says salmonella because we learned that in medical school. And it is true that you need to remember that they are more susceptible to salmonella because of relative asplenoly, but they're still more likely to have a Staph aureus infection just like the rest of the population. Immunocompromised children are more likely to have infections from less virulent microbes or fungi than the healthy child. Certainly in our neonates, they're going to have more likely exposure to group B strep and some gram-negative organisms. And then in our sexually active adolescents, we need to also think about gonorrhea. Gonorrhea is important, particularly in the setting of a septic arthritis discussion, because gonorrheal infections, which are most commonly in the knee, are the one septic arthritis that actually just needs antibiotics and not surgery. So it's really important in taking care of your adolescent patients to ask those difficult questions around sexual activity and see if potentially that is a risk that we need to evaluate for. So because there's potential for joint destruction and systemic sepsis, the stakes are really high with septic arthritis, and so we need to be really expedient and accurate with our diagnosis. In terms of a child presenting, that's the differential that you want to think about. But these kids are coming possibly with a history of a recent local trauma or a recent illness or infection, not always, but you definitely want to ask those questions. A vaccination history is really important to ask about, and we can't unfortunately assume that everyone has been vaccinated. Travel history and sick contacts are really important to inquire about. And then if they've had any recent or current antibiotic use that could be masking symptoms, it's really important to know when we're talking about infection. For the physical exam, when you're evaluating for a septic joint or a musculoskeletal infection, obviously we want to know if the child appears ill. Particularly with a septic joint, particularly a large joint like the hip, they usually appear quite ill, like the little kid in the picture, kind of flushed, not really wanting to move. They tend to be febrile. They have a reduction of spontaneous motion or something that we call pseudoparalysis, where they just don't want to move the affected limb. This is a really important finding in neonatal infection, where babies in the NICU or babies who are recently discharged home, if they just stop moving their arm or their leg, it's important to really pick up on that. So looking for spontaneous movement is important because pseudoparalysis can be then a marker of infection. Refusal to bear weight if they're an ambulatory child and they do not want to get up and walk. That's an important thing that you need to look for. If you're the physician or the practitioner evaluating the patient, you actually want to make them try to walk as opposed to just having the parent say, oh, no, they won't walk. Because I've been told many times by people that they're refusing to bear weight, and you go down to the ER and you tell the little person that you need to see if they can really walk on their leg, and they limp around the room, which is not a refusal to bear weight. So make sure you actually do that clinical exam yourself when evaluating for weight-bearing refusal. And then doing a passive range of motion exam is going to be really important for both septic arthritis and osteomyelitis. But a septic joint is a painful joint. And so if it's got infection in it, usually any amount of motion of the joint is painful. But early on, it might be a little bit more subtle where you can sort of do central motion reasonably, but terminal extension and flexion or sort of the terminal movement of the joint might be painful, whereas if you keep it kind of small, you might not pick up on it. So make sure that you start gentle, but then you try to take them through full motion and see if you can get full motion or not. On examination, obviously in some cases there's going to be palpable swelling and effusion on exam. So the elbow, the wrist, the knee, the ankle, those on physical exam, you can actually look at the joint. You can see that something's fishy because it might be swollen. It might be red, maybe not quite as dramatic as that knee picture. But you're going to be able to tell on physical exam that there's a problem with the joint. The hip and somewhat the shoulder are different, where you're not necessarily going to see swelling of the hip. It's a very deep joint, and depending on the size of the patient, you will potentially see nothing abnormal on the skin. And so you have to be just aware of that. You want to obviously look for erythema or cellulitis. We get called a fair amount on the orthopedic side for evaluation of a septic joint, where there's no effusion of the underlying joint, but there is cellulitis. Cellulitis is a medically managed condition. Septic joint, more likely a surgically related condition. So it's important to distinguish between something that is superficial cellulitis and something that is a deep joint infection. So the presence of an effusion of the joint is going to be the marker of that. So much of our exam and our evaluation is to really assess what level is this problem. Is it just the skin or is it something deeper? Clinical exam of a patient with a septic hip is going to look like that top corner, where you have a patient that's laying with the hip flexed, externally rotated, and abducted. And that's because if you put your hip in that position, your capsule is the most open. So you're really reducing the pressure in the joint and reducing the pain. I will say that definitely been consulted on kids for rule out septic hip, and I come down and they're curled up on their side, watching their iPad. I already know right there, that's not a septic hip, because they would never sit with that position. If there's truly an infection in that hip, they're going to be very guarded and sitting at least neutral, if not in that position that you see there. And again, on the hip, you have to be careful because you're not going to see erythema or swelling. For the evaluation of the elbow, the wrist, the knee, and the ankle, that could be quite straightforward. You're going to do labs, get an x-ray, and do an aspiration if you have an effusion of that joint. And I can say that sort of flippantly, because it's actually quite easy to do an aspiration of those joints because they're quite superficial. We have sort of known portals that we can go in to easily access the joint. And the best way to know if something is septic is to send off fluid and see if it is consistent with infection. For the shoulder and the hip, though, it's not so easy to aspirate those. So your evaluation involves a lot more sort of thoughts and steps, which is why if you're an orthopedic person, you know that when we talk about septic arthritis as trainees, we're pretty much just talking about the hip. And certainly if you're on the pediatric side or the ER side, you probably have heard a lot about the discussion about distinguishing between septic arthritis and transient synovitis, because this is the conundrum that makes the hip the most sort of interesting to talk about when we talk about septic arthritis, because not only is 35% of the septic arthritis hip, but the hip also has this sort of thing of having transient synovitis, which is quite common. And it's very important to distinguish between the two of them. So what is transient synovitis? Well, it's the most common cause of acute atraumatic hip pain in children. So not septic arthritis, but transient synovitis is the most likely thing to be causing acute atraumatic hip pain in a young child. That hip pain is usually due to a transient inflammation of the synovium of the joint, likely related to an infection previously in another part of the body, but not actually an infection in the joint that's currently inflamed and unhappy. It's usually unilateral, which is just like septic arthritis. We don't really understand why this synovial sort of irritation happens. We got a lot of theories about it, like I said, related to a previous, like recent infection, but we don't actually understand why it happens or why the hip is the most likely joint to be affected. It can be bilateral, which septic arthritis, unless the child is horrifically ill, usually is not. It is self-limited, unlike septic arthritis. It does account for a fair number of admissions and presentations to our emergency rooms because it's really important to sort out, is this transient synovitis or septic arthritis? And it unfortunately is a diagnosis of exclusion. There's not like a test you can do for your transient synovitis test, yes, no, because my God, that would make our lives better if that existed. But really you have to go through a lot of steps to figure out, is it transient synovitis or is it septic arthritis? And really the presentation can be quite similar to hip septic joint. So let's compare, just sort of starting off. A transient synovitis kid is gonna look unhappy, but okay. Whereas a septic arthritis kid usually looks pretty ill. Transient synovitis can have a low-grade fever. A septic arthritis patient tends to have a higher fever, but there's no that's not definitive, right? So these are generalizations. The transient synovitis patient will resist the extremes of motion on exam, particularly opening up the hip. But a septic arthritis patient will resist motion pretty much in any plane. That's why sort of starting gentle, but then going through wider motion is really important on your exam. In transient synovitis, they may or may not be able to bear weight, and usually in septic arthritis, they cannot. Transient synovitis usually has some sort of viral illness recently. Septic arthritis can have active infection at the time or something recent. Laboratory studies are the first step in being able to discern, is this something we need to do something about or not? Your CBC for their differential is critical, looking for a left shift. The white blood count is not particularly specific in terms of the number, but if it has a left shift, that's obviously concerning for infection. Your C-reactive protein, your ESR, and blood cultures are all important to get. We'll talk about each in a second. And then it's really important. So I trained in Boston. We check Lyme titers on everybody. Allie's from Connecticut. She checks Lyme on everybody when we're in those places. It took me a little while to remember when I moved here that I don't need to check Lyme on everybody, but it is important to ask, right? We have patients that travel all over. Maybe they were just visiting Lyme, Connecticut to visit their family, and they went for a hike and got a tick bite, and now they're here and they have a painful joint. You got to ask those questions so that we make sure that we rule out Lyme, because Lyme does not need surgical treatment, right? So again, like gonorrhea of the knee in an adolescent, we don't treat Lyme with surgery, we treat Lyme with antibiotic. So you guys doing okay? Okay. For our white blood cell count, again, the differential is what's important. The left shift you're gonna see most commonly, that's your most sensitive thing when you're looking at your white blood cell count. CRP, we'll talk about both with osteomyelitis and septic arthritis. This is really the powerhouse of infection evaluation, must get on every patient. If ever you can only get a tiny bit of blood from your patient, please don't send it for a CBC or an ESR. Send it for a CRP. Absolutely the most important test that we can send. So that's your most important go-to. It's going to rise the most rapidly, so it's going to be a marker of infection very early on in the disease. And it also falls the most rapidly if you are appropriately treating that child. So it's a great marker of, are we on the right antibiotic? Have we done the right thing? Do we need to change up our plan? If it's low, you also have a very low risk of having septic arthritis, and I'll show you some data on that. And it's definitely more sensitive than a white blood cell count or an ESR in terms of assessing your intervention. ESR, which is the one we used to talk about all the time until it got surpassed by the CRP. The peak of an ESR takes a lot longer, so 3 to 5 days, and then it remains elevated for a much longer period of time. So it both tells you later that you have a problem, and then it stays high for too long to tell you if you're doing the right thing or not. We always get it if there's enough blood, just because it's like a little reassurance, but it's not the one that really drives our treatment decisions. And then blood cultures are really only positive in about 30 to 60% of patients. So they're helpful if they come up positive, because then you know what your organism is, and you can stop worrying about what are we actually treating. But if they're negative, it doesn't mean you don't have an infection. And it also means you don't exactly know what you're treating, so you have to use community standards in which to decide. So if you've ever worked in an ER or in an urgent care clinic or on an orthopedic service, you know something called the Coker criteria, which is like the landmark paper that came out in '99 that helped us actually distinguish between septic arthritis and transient synovitis. Prior to that, you had to like aspirate every hip to see if it looked like it was infected or not. And a ton of kids got a lot of surgery for transient synovitis that they didn't need. And so in very brief, the study really tried to look at a retrospective study looking at all the kids that presented to Boston Children's with septic arthritis versus transient synovitis and tried to come up with laboratory evaluation that could help you sort of quantify what the risk of septic arthritis was. So a white blood cell count greater than 12, an ESR greater than 40, temperature greater than 38.5, and an inability to bear weight were significantly predictive of septic arthritis. If you had all four of them, then you had, as you can see, a 99% chance of having septic arthritis rather than transient synovitis. They repeated the study a few years later, kind of changed up a little bit of the design, and it was not quite as predictive, but you could see that the data still really supported that if you have all four of those, you are like gonna need to operate on that child. And then you can see how if you reduce the number of those things that are at the threshold, then your predictive value for septic arthritis goes down. So this has been really helpful. When they added a group out of Children's Hospital Philadelphia a few years later, added CRP, once CRP became like a thing we could get. And you could see that when you added CRP, it sort of brought it back up to that high predictive value that you saw in the first Coker study. And there's subsequently been multiple studies that have looked at CRP. And really it is the strongest independent risk predictor for septic arthritis. It's really important. You saw that I put 20 milligrams per liter and 2 milligrams per deciliter. Within this region, we have some hospitals that use milligrams per liter and some hospitals that use milligrams per deciliter. So if somebody tells you a number, you have to know what their scale is. Otherwise, you might assume that the number is normal when really it's catastrophically high. So always make sure that you know the units associated with the number that you're given. And I have called many a hospital in my life to be like, are you milligrams per liter or milligrams per deciliter? Because you didn't write it down. And that makes a big difference. So if the CRP is greater than 20 milligrams per liter, which is the equivalent of 2 milligrams per deciliter, and they are not weight bearing, you have basically septic arthritis. Those two together are the most important independent differentiators between septic arthritis and transient synovitis. And if you have neither of those, then it's a less than 1% chance of having septic arthritis. So really important to get the CRP and to try to get that child up to see if they will walk. All right, so critically important part of your exam. In terms of imaging of the acutely painful hip, you're gonna order your imaging simultaneous to your labs. So don't get the labs and then wait for them to come back and then start your imaging. You should get both. If you are concerned that a child has a septic hip, you should order your imaging and labs all at the same time. Most people start with a AP and frog lateral of the pelvis, which you can do, but it is actually much less important than getting the ultrasound, unless there's a history of trauma, and then that x-ray is gonna be as critically important to rule out fracture. Bone scans we'll talk about for 2 seconds, and MRI as well. So for the x-ray, so you're gonna get an AP and a frog lateral. This is to rule out fracture, and you're checking for widening of the joint space. You have to have a massive effusion to give you enough of a joint space widening to actually be able to tell the difference. So that's why this is not the great test to actually see if there's infection. Here, you're really just checking to make sure there's not a fracture accounting for why this patient is in pain and not walking. And 2, you're also looking to see if there's any signs of osteomyelitis here, which we'll talk about in a bit. In terms of the important imaging to get, you're gonna wanna get an ultrasound of the hip, and you need to get both hips. So it doesn't actually help us to do one hip because there's always some amount of fluid in every joint. And so if the right hip is painful and the left hip is not, the left hip is gonna serve as your comparison for how much fluid should be in that joint. And then when you image the other side, you'll be able to see if there's an effusion or not. So it's quite sensitive for detecting a hip effusion. All right, if there is no effusion, it's highly unlikely that you have a septic hip, because by definition, septic arthritis is a infected effusion of a joint. And so important to make sure that we know that. This is just a study that sort of looked at the value of ultrasound. And I just want to point out at the bottom that ultrasound should be used to confirm whether or not there's an effusion, not that it's septic joint. So transient synovitis is also an effusion. You can get inflammation of the synovium and an effusion. Septic arthritis is an effusion. If you have an effusion, then your labs help you decide between transient synovitis and septic arthritis. If you have no effusion, you're not having this debate with yourself because you don't have the risk of a septic hip. Does that make sense to everybody? There's many an orthopedic resident I've had to review that with. When we talk about MRI, never order an MRI as your first thing because MRIs take too long to get. And in the setting of a concern for infection, you got to move a lot quicker than an MRI will let you do. If you're in a place where you know that you have a septic hip and you can get an MRI basically on your way to the OR, then you would get an MRI to see if there's also osteomyelitis so that you can treat it at the same time. But we never wait to go operate on an infected hip while we're waiting to get an MRI. So if it's in the middle of the night and a kid comes into the ER and there's a hip infection that we're worried about, even if we can't get an MRI to look for if there's any other infection, we're going to take the kid to the OR, we're going to operate on the hip, and we'll get the MRI later if we need to. We do not sit on joint infections, particularly of the hip, all right? So if this is a kid that shows up to your clinic at 5 p.m. on a Friday and you're concerned that there's a septic joint, that kid needs to go to the ER for all the things we're talking about here. This is not something that we want to sit on. Bone scans really, Dr. Kamen, sorry that I'm talking about your area of expertise. I will just say that bone scans from an orthopedic perspective, we really only use these if one, we don't have access to other things, and two, we're like not sure where the problem is in the body, or there may be multiple sites involved and we need to figure out what all those sites are. So we don't use it as a primary evaluation. If after you've done your ultrasound and there is an effusion, so then you've thought about your Coker criteria plus your CRP, and it's very low risk for being a septic joint, then you can empirically start treatment for transient synovitis, which is just activity, rest, and NSAIDs. And really you should see a marked improvement in the symptoms. It says 48 to 72. It really should be within 24 to 48 hours. And this hip can be completely normal by about 10 days, but you should see a marked improvement very early on. And if we think, for example, that there's a kid in the ER that has a low risk for having a septic joint, but maybe they have 1 or 2 Coker criteria, but not the CRP and not the refusal to bear weight, we will admit them to the hospital, keep them NPO overnight, check their labs the next morning, and make sure they're headed in the right direction, not the wrong direction. Because if their labs are trending upward, then we might need to intervene. So if you have a child that you're worried about, it's okay if they're very low risk for a septic joint, just like based on all the criteria we talked about. You can allow them to go home, but they got to touch base with that family first thing the next morning, get some new labs, follow up. The hip that I showed you at the beginning, which had no femoral head anymore, and that child's life will never be the same, was a case of a very early presentation to their primary doctor. It wasn't clear at the time if it was septic joint or transient synovitis, and they told the family, take NSAIDs for 5 days. If it's not better in 5 days, then come back. Well, the child got sicker and sicker and sicker, but they waited for 5 days like instructed, and by the time they came back, she was in septic shock with a destroyed hip. And so we just need to be very clear with the families that you can go home, take this medication, I'm going to check with you tomorrow, or my team's going to check with you tomorrow and make sure that we're getting better, not worse. If you're not sure, right, if we're not sure if there's an infection or not in the hip, or if it's one of those other joints that's very easy to tap, we're going to do an aspiration to pull off that synovial fluid. That can either be done by radiology under ultrasound guidance. Thanks for doing that for us sometimes. Or by the surgeon in the OR, which bummer if we have to take a kid to the OR and then they're not infected, but sometimes you have to do that just to keep the child safe. And then there's a whole criteria for what's a transient synovitis versus an infection that you probably don't need to know unless you're the one making the decision based off that aspiration. You should know that if there is a septic hip, that the only treatment that is appropriate at this point is still an irrigation and debridement. I would go through the details of the surgery, but you probably don't need to know it. But hips, shoulders need to be treated with surgery. Still, in many places in the US, we treat every infected joint except for maybe fingers and toes, and parts of the pelvis with surgery. There's some data out of some European countries with some of the lesser joints, the smaller joints, that maybe we don't need to treat them surgically. But I think that decision needs to be made by the surgeon who's going to be medical legally responsible for that decision. So definitely, if there's a septic joint, a surgical discussion should be had. And in certain cases, maybe we'll just aspirate the joints repeatedly to draw off any accumulated purulence. But for the most part, surgery is indicated, and particularly for the hip. After surgery or your aspirations and lavages, depending on what joint you're talking about, then you would start antibiotics. So it's important to get the fluid off if you can before antibiotics are started. So if you're in the ER and you have a stable patient and you know that they have an infection, maybe don't start the antibiotic until fluid has been obtained, again, so that we know what we're treating and the antibiotics can be optimally tailored to that child's infection. When you don't have fluid and you need to start treatment, then you kind of base that on your geographic area, what we know about the epidemiology of infection in the region, the age of the patient, and their medical comorbidities, like the things we already talked about. And then we start with IV antibiotics until the clinical picture improves, and then you move to oral antibiotics. I will say that we are blessed here to have an amazing infectious disease team and infectious disease doctors in the United States who manage the medical side of infection. And so blissfully as surgeons, we don't necessarily have to make all those antibiotic decisions in terms of duration. And there's a wealth of literature on how we should treat these kids. And then that duration of treatment is going to depend on clinical judgment and the objective data of the patient. So usually, though, it's about 2 to 5 days of IV antibiotics. Once they're clinically improving, their CRP has halved, then we can move to POs, monitor them on POs, and then they go home on POs, again, usually for about 3 weeks for septic arthritis, much longer for osteomyelitis. And then you just have to be careful about those special populations. So my brief, so you can tell that I'm a graphic genius, and I'm really, somebody needs to teach me how to use Canva or something, guys. Okay, so this is the best I could do with my little algorithm for how I treat this, and definitely need to elevate my graphic game. But if you have a patient who you suspect has septic arthritis, you need to then do the physical exam. That you would sort of be able to discern if it's septic arthritis or not. Do your labs and your imaging at the same time. If your findings are concerning for septic arthritis, you're going to do an aspiration. If the aspiration is consistent with infection, you're going to do surgery and then long-term antibiotics. If the aspiration is not consistent with infection, then you can treat with NSAIDs, because now you're in the transient synovitis category. You have to very closely monitor that patient, recheck them frequently, including with labs in 24 hours. If at some point those labs are trending the wrong direction and the exam is worsening, you're going to take that child to the operating room. Well, the surgeon is going to take that child to the operating room. If we miss this, it has disastrous consequences. So they can actually go into full-blown sepsis, have to go to the ICU and die from sepsis. Chronic osteomyelitis can develop, which I'll show you about in a little bit. They can get pathologic fractures through the surrounding, in the hip that has the infection, it moves into the bone, then pathologic fracture can develop. The growth plates that are in the joints that are infected that have the growth plates in them, those can go on to arrest, and the children can get severe deformities and leg length differences. They can lose their femoral head, their joints can become contracted, their hips can actually just sublux and then ultimately dislocate. And then you can have antibiotic, of course, associated complications, but ideally those are much less risky than all of these other things. And this is just 4 of many examples of totally obliterated hip joints because they were missed infections. Moving on to an equally happy topic, acute hematogenous osteomyelitis. Woo! All right, so this is an infection in the bone. We just covered infection in the joints, so now we're going to talk about infection in the bone. This is much more common, so 1 per 5,000 children, usually also in the first decade of life. With a mean age about 6.5 years. Younger kids more susceptible still, but this osteomyelitis has a higher age range as well. Usually this is just in one site, although neonates are at a higher risk of having multiple bone sites involved. And MRSA also has a higher risk of polyostotic infection. Children who have any of those conditions are at higher risk of having bone infection, which are many of the same conditions that put you at higher risk of infection in general. So anemia, malnutrition, poor hygiene, coexisting infectious diseases, sickle cell, immunocompromised, JIA, and diabetes. This too, like septic arthritis, is caused by hematogenous spread. So if you have a ear infection or pharyngitis, or you're brushing your teeth aggressively and there's transient seeding with bacteria, and then you have combined with some recent local trauma, which gives some hyperemia and vessel damage to an area of bone, then you can increase your risk of infection. Or if there's, again, a direct inoculation like we get with a puncture wound or open fractures. Why this happens, in case anybody's like, I do not understand why this happens more in kids than it does in adults, when why would that be? And it's really because of the anatomy of the metaphysis of children's bones, that in a child, there is a open growth plate, like you, look, I can walk. So we have an open growth plate. We have this area of sinusoidal vessels. So the growth plates have a lot more blood flow to them in the metaphysis of the bone than a skeleton that has closed growth plates. So there's this sinusoidal collection of vessels, and there's some sludging of like a slowing of the flow through that area. So you can think of it very elementary, like the bacteria have more time to like jump out into the bone from the bloodstream because of this sinusoidal vessel collection. And so that's why kids get more bone infection than adults. Usually they have 3 to 4 days of symptoms before they start really complaining. They can have fever, lethargy, and anorexia. They have pain usually at the site and limited use of that extremity. The femur is the most common bone, and then the tibia and the humerus, as you can see there, sort of the distributions. Again, localized pain, a limp if it's the lower extremity. Obviously, if it's the upper extremity, then just a failure to use that limb. So that's that pseudoparalysis phenomena that we were talking about. You'll see swelling around the area of the bone that has the infection, possibly some erythema and cellulitis. And then if it's a chronic infection, then you can actually see a draining sinus tract, which is infection coming from deep inside the bone and draining out through a tract, which I'll show you a lovely picture of later. The x-rays don't really show much in osteomyelitis until the infection has been going on for at least a week. The only thing we might actually see on x-ray is some soft tissue swelling and some blurring of the fascial planes, which your fabulous radiologist will probably read into the report for you. So if you see that and you're concerned about infection, you want to make sure that child gets evaluated and ideally started on treatment before they start to show x-ray changes. Because once they start to show lytic and sclerotic areas or periosteal reaction, that means that infection has advanced and might require surgery. In terms of the evaluation, you would get an x-ray to evaluate it. If there's a concern, then an MRI is really the most valuable other test that just sort of goes through the pros and cons of the different studies. But unlike what I just told you with septic arthritis, where an ultrasound is really important, we don't tend to do ultrasounds for the evaluation of osteomyelitis if we're in an area where we have access to x-ray and MRI, because the ultrasound is not very helpful. So just like with septic arthritis, we want to get a white blood cell count, a C-reactive protein, and an ESR. Same thing here though, the CRP is absolutely your most important one to get. So 98% of acute hematologic osteomyelitis patients will have an elevation of their CRP. It too, just like in septic arthritis, goes up fast and responds rapidly to treatment. You can see the ESR is probably better for osteomyelitis than it was for septic arthritis, but the white blood cell count is sort of abysmal, with only about 25% having an elevation. When again, blood cultures, not very positive in many cases. In general, in infection, you're going to start hearing more about procalcitonin, which if you have it available to you, people are ordering, and it does tend to be elevated in cases of AHO. And it's actually better because it doesn't doesn't elevate in the setting of like viral illness. It really is a bacterial marker. And so it helps discern infection. And then obviously if we can aspirate the bone, then just like a joint aspiration, a bone aspiration will help us identify the organisms. But again, we're limited in terms of what comes back as culture positive. Same thing with septic arthritis in terms of what organisms we see. The only thing I would add, which I didn't talk about before, is tuberculosis. And if you're in an area with high tuberculosis rates, which we have some increasing rates in California, or you're taking care of patients who are from areas where they might have been exposed to tuberculosis, you always want to think about tuberculosis. Where I work in Uganda, 10% of our osteomyelitis kids have concomitant tuberculosis on top of their Staph aureus without any pulmonary manifestations of their tuberculosis. So they're all extra pulmonary osseous only tuberculosis cases. You also can get Pseudomonas coccidiomycosis and E. coli infections as well. And this is just an example of why it's important to know what your actual region has in terms of infection. And then certain things obviously specific to certain age groups like we talked about. The treatment for acute hematogenous osteomyelitis, if there's no joint involvement, so if there's a septic joint, it's a surgical problem. If there's no joint involved and they have not had symptoms for a long period of time, you're going to start on antibiotics as long as there's no x-ray changes. And you're going to treat for 4 to 6 weeks. Like bone infections take a long time to treat, and sometimes we see chronic infection in the setting of undertreated acute infection. If they have a septic joint, if they've had symptoms that have not responded to antibiotic treatment for the last 48 hours, if they have any known soft tissue or bone abscesses, all of those are going to go to the OR. If the x-ray shows that they have a lucency or certainly some dead bone on x-ray, that's a surgical problem. And then MRSA you have to be really careful of, because again, MRSA osteomyelitis kids are quite ill and can go downhill relatively quickly. Just important to think about the different ways that kids could get infections and how that changes our antibiotic treatment. This is one of those first landmark MRSA studies that really showed us that we have to take MRSA infection very seriously because MRSA osteomyelitis has an increased need for surgery, increased length of hospital stay, polyostotics or multiple sites infected. They usually have to go to the ICU. They require much more antibiotic care, and they actually have a higher rate of DVT and PE. And so we think that's probably related to that PVL gene, but when the study first came out, they weren't testing for that specific gene. So with osteomyelitis, then just if you have a stable patient and there's no immediate plan to take tissue out to get cultures, then you would basically start antibiotics based on what your community metrics are. If you have an unstable patient, you're going to start antibiotics, broad spectrum antibiotics, and let it sort out later if you're going to get any additional studies. You do have to be careful with osteomyelitis to be aware of what could be a blossoming septic arthritis. So again, if you have a metaphyseal osteomyelitis, it can move into the joint if it's in the proximal femur, the proximal humerus, the proximal radius, or the distal tibia, because all of those are interarticular metaphyses and can move into the joint. If we don't treat these effectively, we can get a chronic infection where you can get avascular necrosis, growth disturbance, pathologic fractures, DVTs, and sepsis. If an acute hematologenous osteomyelitis moves on to become a chronic infection, this can be due to a delayed or misdiagnosis, the inappropriate antibiotic treatment, treating a resistant organism with a medication that's not appropriate, or an insufficient surgical management. You can develop a chronic osteomyelitis. And I just want to go through this mechanism of how this develops. So this is just that's a pocket of pus in the middle of the metaphysis, right? So you can imagine this was your growth plate, this was your sinusoidal vessels, little bacteria crawled in there, did not get treatment. Those little bacteria started to thrive. They created dead bone. Then that proliferated more bacteria. They started to form this pus. If that pus does not get treated with a decompression, pressure will build up and it will move itself out of the bone and break a hole into the cortex and start to form an abscess in the subperiosteal space. If that subperiosteal infection doesn't get caught and treated, it will continue to proliferate more and more pus, and you'll see more and more periosteal stripping of bone. And once that takes the periosteum off the bone underneath becomes devitalized because bone gets its blood supply from the periosteum. If you strip the periosteum off the bone dies, and it's a terrible catastrophic event. It leads us to chronic osteomyelitis, which is when acute osteomyelitis has evolved into a state of chronic infection in which you have persistent devitalized bone and or dead debris. This is an absolutely tragic preventable condition that we see in people who do not have access to care here in the United States and in thousands and thousands of children in limited resource areas where they are not getting treatment for acute osteomyelitis. These are just, this could be one day in clinic where I work in Uganda, where it's just a constant entrance of more and more patients with chronic osteomyelitis. What you see with chronic osteomyelitis, if it goes on long enough, is that this was actually the child's original ulna, but it has become totally devitalized and is actually just a piece of dead bone surrounded by a bone that tried to heal. So this is sequestrum, this is involucrum, this is a septic joint with a dislocated radial head. And then you can see sinus tracts on this child's arm where multiple places the body started to express pus out of the arm. And so this happens a lot, and this is why it's important to treat acute osteomyelitis correctly. Many of these children are then malnourished and anemic. This puts them in a catabolic state, so it's really hard for them to heal from this infection. They need a lot of nutritional support both before and after surgery, and often some blood products, which is hard to get in a resource-limited environment. We do see this here in the United States, just not anywhere near the rate that we have in other places. And it's really important that these kids get treated by people who know how to take care of this condition, because sort of under treatment will lead to, significant problems over time. And finally, in my last 1 minute, we'll talk about, just to acknowledge, the other musculoskeletal infection which can happen in kids, which is discitis, which is an infection of the disc. This is also secondary to a systemic infection. They come in with fever and back pain, a refusal to sit or walk, painful limp, loss of appetite, fever in some cases. Abdominal pain is a very important thing to pay attention to, as it might be discitis. They can have tenderness on exam in the area where they have disc involvement, and limited range of motion of the spine. This is more common in boys than girls, usually in kids under 5, and the lumbar spine is the most common area to get it. Just like all these other infections, Staph aureus in the US is the most common, but we can see tuberculosis, so like Pott's disease, for example, is tuberculosis of the spine, and in young kids can start as a discitis. And always you want to think about salmonella in the sickle cell population. Treatment is antibiotics, and we do surgery though in the setting of abscess. Obviously if there's an associated epidural abscess, then we need to get that child treated. We use bed rest and sometimes a brace for these. And blood cultures and MRI would be how you evaluate this. And just like with osteomyelitis, where the uniqueness of the pediatric skeleton puts children at more risk for osteomyelitis, the discs are the same. So in children, the blood vessels extend from the cartilaginous end plate into the nucleus pulposus, into the disc itself, which is why a transient bacteremia can take root into a disc. But in adults, the blood vessels actually extend only to the annulus fibrosus. So you don't see discitis in adults like you do in kids. So in summary, make sure, please, that you think about infection in the setting of pain. Make sure you ask history questions to rule out infection, that you think about it on your physical exam and do the appropriate evaluation. And when you're doing your physical exam and diagnostic imaging, make sure that you're thinking about these things. When we catch it early, osteomyelitis is a medical condition. If we catch it late, osteomyelitis is a surgical condition with possibly devastating consequences. And septic arthritis is always a surgical condition, so please refer emergently if you're concerned. And it's always helpful to have an orthopedic friend available to call if you're not sure, and we're always happy to help because we never want to lose a hip. Thanks.